Good afternoon, everyone. Thank you for joining us today for the BC Renal CKD e-learning series. I'd like to acknowledge with gratitude that I live and work on the unceded and ancestral territory of the Lekwungen people, known today as the Esquimalt and Songhees nations. It's my pleasure to introduce our speaker today, Dr. Micheli Bevilacqua, to discuss hypertension and CKD. Dr. Bevilacqua is a nephrologist with additional training in health administration, and his clinical practice is based in British Columbia in Surrey. Beyond his work with patients, he plays a key leadership role in shaping kidney care across the province. He serves as the chair of the Provincial Kidney Care Committee, coordinating multidisciplinary care for more than 15,000 British Columbians living with chronic kidney disease. He's also the medical lead for the BC Polycystic Kidney Disease Network and the co-chair of the Transplant First Committee, both of which focus on improving outcomes and access to care. In addition to these responsibilities, Dr. Bevilacqua is actively involved in research with interests in polycystic kidney disease, knowledge translation, systems improvement, and evaluating kidney care delivery. Please join me in welcoming Dr. Bevilacqua for our presentation today. I will hand it over to you.
Great. Thanks so much, Sidoni. Thanks for the kind introduction. I'm just pulling everything up. Great. You should be, yeah, perfect. We're seeing things there. Great. So yeah, the topic we're going to talk about today is hypertension management and chronic kidney disease, which may seem like a straightforward statement, but the goal here is we're actually going to break apart, where all the recommendations come from to help us better inform our decisions in our patients. To get started, before we get into the specific outline, just a few disclosures here. I should say many disclosures, but pertinently, none of these are related to anything around blood pressure management or those drugs. Most of those drugs are now off patent anyways, and you'll see as we go through this, I won't actually be talking about any specific agent whatsoever, so that should mitigate that conflict, any potential conflict there. Okay, but so in terms of what we're going to cover today, it'll be kind of a whirlwind tour of blood pressure in chronic kidney disease. And one of the specific parts we're going to focus most of our time on is exactly what the evidence is that underlines the various guidelines we have, because I know it can be a bit confusing with all the guidelines out there, to really break apart when we're individualizing our treatment for our patients, who do we set what target for and who needs specific drugs. So we'll go through that in a whole lot of detail, and that's going to be the bulk of our talk there. But maybe to start, it is worth just kind of setting the stage here. As I'm sure you all are very well aware in the primary care world, hypertension is very, very common. Depending on what series you're talking about, it could be even up to close to a third of Canadian adults have hypertension, so quite a lot of them. And one of the well-published numbers, and you may have even seen this advertised through various things through the Kidney Foundation, for example, is that about 10% of adult Canadians have some degree of chronic kidney disease. Through those clinics that Sidoni had mentioned, for example, we know just a little bit less than 20,000 of those patients, which means that that's a vast underestimate. Most of these patients are living in either the primary care world or undiagnosed, as we know is the case. Many of our CKD patients have hypertension, so this is a big, big scope of an issue. And even though it might just be a smaller amount of them where we say this is the specific cause of their kidney disease, blood pressure management in the context of chronic kidney disease is a cornerstone regardless of what the cause is. So I just like to set the numbers to show this is a really, really big scope of a problem. And for our chronic kidney disease patients, it's essentially the norm that we have to worry about blood pressure control. And we don't just worry about it because we like to look at numbers because we're nephrologists, although that is true. What we really care about is that, there's all kinds of outcomes that this is related to. We know that blood pressure is specifically related to their renal outcomes. So this is kind of showing the incidence of end-stage kidney disease. And you can see it tracks very specifically depending on what their blood pressure control is. And of course, as many of you are going to be aware, it's also related to their cardiovascular outcomes, which always sounds funny that we talk about that a lot as nephrologists. But the reminder there is that chronic kidney disease patients or even end-stage renal disease patients mainly die of cardiovascular disease, not renal disease. It is the outcome we're thinking a lot about in our kidney patients. So it's very clear that this is related to their outcomes. None of that is news, but the part that I wanted to kind of add in is that it can sometimes be a little bit hard to know what's the chicken and what's the egg. although we often talk about the whole, Occam's razor concept, where it's best to have one unifying diagnosis and the simplest, most straightforward explanation, the kind of exception to that is when you're dealing with multiple very common things. So we just went through that hypertension is common, kidney disease is common. So the point that this slide is making, and you don't need to know all these little algorithms here, but it's basically saying not everybody who has hypertension and chronic kidney disease has hypertensive nephrosclerosis. In other words, you might have a different kidney disease and happen to have high blood pressure. And conversely, and the one that sometimes is hard for people to wrap their heads around, is not everybody with hypertensive nephrosclerosis actually has high blood pressure. In other words, there is a group of people, and you may have seen and shared some of those patients with us, that ultimately we even go ahead and do a kidney biopsy on because it's not clear what's going on with their kidney disease. And we see very classic findings of hypertensive nephrosclerosis, but you go back and their blood pressure was never really all that bad. We're seeing it at the microvascular level. So you see both sides of the coin. So just because they coexist, it means that you don't necessarily know exactly what's the cause of this here. And that's why the first point I want to make before we get into the targets is just to avoid this concept of premature closure of the diagnosis, meaning we sometimes get, patients where we're told, oh, this patient has hypertensive nephrosclerosis, please see. And you go back and actually, maybe they haven't really had high blood pressure all that long, or there are some other findings. So it does make it worthwhile to make sure we've ruled out other causes of kidney disease. And I have here a few things that tend to be associated with you being more confident in this being hypertensive nephrosclerosis. And the flip side of that being, if you don't see these things, maybe go looking for a different diagnosis. So, if somebody's had a blood pressure for a long time, they have other findings, other manifestations of hypertensive complications. They don't have a lot of proteinuria, and there's nothing else going on. Great, then we can kind of chalk it up to that. But outside of this, it really is worthwhile to do a screen for causes. And either you can kind of get that started, or this might be somebody where you say, hey, this doesn't quite add up. Do you mind seeing them as the nephrology team? And we can do that workup. And the last part, I often do catch this, things like hyperaldosteronism as a classic example, secondary causes of hypertension, are present in 10 to 20% of patients, depending on what series you're looking at. So if they don't fit this pattern, or especially someone who's got a young age of hypertension onset, you definitely want to make sure you've done that screen for secondary causes of hypertension. Okay, so I just wanted to cover that quickly just to say it's not always a straightforward relationship. Make sure we haven't, that we've ruled out other causes of it. But otherwise, we're going to spend most of our time talking about the actual management, because that's the bulk of this. And actually, one of the things that I think can be a bit confusing. And the reason why it can be confusing is because of all the various guidelines and all the various targets that have changed over the years. So I have in here 3 sets of guidelines. We have Hypertension Canada, which a lot of people, might be very familiar with. This one in the middle these two called KDIGO, that's kind of like the Bible of nephrology, the kidney disease improving global outcomes. That's where we go as kidney doctors for our guidelines. And I have them as an example to show how they've changed over the years. So we've got the Hypertension Canada one here, which you're probably pretty familiar with, where it talks about, diabetes, non-diabetes, and has some various targets. Our older version of the KDIGO guidelines, our kidney ones, used to say pretty much a similar thing, where it would break it down into different categories. But then more recently, it got replaced with just this one statement of saying, think of everybody as being below 120. So I know this is always confusing. Anytime you have this grid of different targets, and then it says, oh, go back and individualize. So what our goal is going to be for most of the talk today is we're going to break down where this comes from to get that understanding of who might you go lower, who is okay with a standard target. So I'm going to take you through a whirlwind tour, and I'm not going to, expect anybody to remember all of this study names or anything like that, but really just the concepts, and you'll see that I'll kind of paint a picture with this. So this goes way, way back. You can always tell, when you see kind of the text and the fonts that are used in a paper. This one is actually 1998 from the Lancet, from what was called the HOT trial. And this was one of the first ones where they were really kind of looking at how does blood pressure correspond to various different cardiovascular type outcomes. And it gave us that U-shaped curve that a lot of people are familiar with, where you want that Goldilocks zone, right? Not too high, not too low, both high blood pressures and very low blood pressures are associated with bad outcomes, probably for entirely different reasons, which we'll get into in a minute. But that's where people were saying, okay, this is the sweet spot when you look at that big, observational trial of saying, yeah, somewhere around 140 over 90 or thereabouts. So then people actually started doing some trials. I was going to say a whole bunch of trials, but it's actually an embarrassingly small amount of trials to try to figure out what is actually the best target. When I say embarrassingly small, here's a few big names that you can look at. And if this were the cardiology world, there would be about 70 different trials in here. But I always kind of joke that between the time that I was in kind of, middle school till the time that I had been practicing for nephrology for quite some time, we had a grand total of 5 different trials in nephrology. So it's kind of just a small number, but it did answer these questions quite nicely. I had kind of highlight here that we have trials that were primarily designed for kidneys, that's the one in green, and others that were primarily designed for cardiovascular outcomes. And that is important because it tells you what type of patients they were after. These green ones are looking at people who are at risk of progression of their kidney disease. These red ones looking at people for whom we're worried about their cardiovascular risk. Okay, so we have kind of 5 big things and then a few observational stuff, and we'll start putting all together where these various numbers come from. The reason I have these numbers here to start, maybe just to introduce the concept, just as a reminder in case people haven't been as familiar with these guidelines. These are the standard evidence grading criteria where the number and the letter talk about the strength and then the quality of the evidence respectively. So a 1A being your highest grade of evidence, multiple randomized controlled trials telling you the same thing. That's kind of the standard for a 1A. And then working your way down, 1B would mean there is some evidence, but not as great. As soon as you get into 2, that's where you start saying there's lesser evidence and some opinion-based stuff. When you get into a 2D, that's pretty much saying we don't have a lot of great evidence and it's opinion-based. I'm introducing that concept because you'll see then it'll correspond to how strong the evidence is versus what's more opinion-based as we go through these trials here. So going back to start looking at some of these, we have non-diabetic. So this is the RAIN trial, non-diabetic kidney disease treated with ramipril, and they were randomized to either a conventional or intensified target. And you can see what used to be conventional. It's because that's when we were just starting off and kind of looking at these trials. And we saw, okay, there was no real difference here in the whole cohort of patients between those 2 arms. But then as we start looking at specific subtypes, so same thing, this goes way back, you can see even further, 1994, the MDRD trial that we still talk about quite a lot, and they were looking at a few things, protein intake, which we're not going to talk about that arm of the trial, but we're but also talking about blood pressure arms. And you can see that they had kind of 2 different arms, the usual target versus a low blood pressure target based on these different MAP goals. And when we look at these, they look pretty much the same, right? When we talk about their GFR progression. So we might just say leave it at that, and this trial didn't really tell us a whole lot. But the reason I'm still talking about it 30 years later is because there were pretty good insights that when we look at the whole group, there was no difference. But when you start splitting it apart to the patients who have higher degrees of proteinuria, that's what these different bars are down here. These are in grams per day, so less than 1 gram, 1 to 3, or above 3, kind of getting into nephrotic range proteinuria. You can see that then things really start to separate. That in those proteinuric patients, there is a very big difference in outcomes with a lower blood pressure target. They lose less GFR. Their rate of GFR decline is less in a stricter blood pressure control if you happen to have a lot of protein. And that effect was seen in a few other trials as well. And this is actually looking at a big meta-analysis that included those trials that we were talking about of non-diabetic kidney disease patients. And sorry, there's a lot of text here, but that's also because I intended these to be used as a handout if you like. But basically what it's saying is that even independent of anything else, when they kind of corrected for everything that they could, they would find that the proteinuria and of course, the level of blood pressure were consistently correlated with their CKD progression. And those 2 items are synergistic. And so what I mean, to get into a lot of details here, is that having high blood pressure will have faster decline in your kidney function. having high blood pressure and high degrees of proteinuria will have, or sorry, having proteinuria will have more rapid progression of your kidney disease. But the two of them together, it's one of those 1 + 1 = 3 situations where the combination of uncontrolled blood pressure and high degrees of proteinuria, you kind of start to get this exponential worsening in your decline. And you can kind of see this go through where, yes, high blood pressure is bad, but all of a sudden, if you look at the group who specifically had both uncontrolled blood pressure and more than a gram of protein, it just starts to skyrocket. So in other words, the people with less than a gram of protein, there was no real difference, but those lines dramatically separate the more protein you have. So why I spent so much time talking about this is in the non-diabetic kidney disease world, it really is telling us that the protein is the driving factor here. And this is where we go back to these various different gradings here, where we start to say, okay, we know for everybody that being below 140 is a good thing. So that's not a surprise. We have better outcomes there. But it's really in those group of patients that have more protein that we can really say they do need that lower target. Oh, sorry, I had my mouse on the wrong screen. You guys can see that. In these group of patients who have more protein. And this is why they're still both not highly graded things, because these were, these weren't specifically randomized trials looking at heavily proteinuric patients. In other words, it wasn't a dedicated trial for this reason. But this is why we have a stronger recommendation for the people who have more protein to say, yeah, you really should get them below 130 over 80. So that's for people without diabetes. But then what about diabetes? Because some of the guidelines that we see specifically say all diabetics should be below 130 over 80. So when we look at diabetes for quite some time, again, this is going back, to 2000, so now 25 years ago, we've known that higher blood pressure in diabetic patients was correlated with worse vascular outcomes, both macrovascular and microvascular, kidneys being kind of one of the classic microvascular ones we're worried about. So we know the higher your blood pressure is, the worse you do. Okay, so that's not a surprise in our patients with diabetes. But this is where, similarly and kind of concurrent or just slightly after some of those other trials we talked about, they started asking basically the same question, is what is the right target? And as the trials progress, it's kind of like going from just any blood pressure to getting it somewhat under control and then more aggressive control. So this would be the advanced trial, one of the kind of seminal trials in this area, where they looked at these combination drugs and also looked at different blood pressure targets. And they saw that, okay, there was a little bit of a benefit in getting people down to below that 140. So that's great. And you can see there is a difference, a separating of the curves here. Again, that's not what we considered low, but you had to start somewhere. They said, okay, let's get them down below that range. When we really looked at getting low, and this is the one I wanted to talk more about, this is kind of the very seminal ACCORD trial, where now they're actually randomizing them to two different blood pressure targets, and one that we would call quite a low target. And they basically were able to achieve that. You can see that, they went through, and yes, you need a whole lot more medications to get to the intensive, what they called at the time, the intensive target, but you were able to do so when you had a nice separating of the blood pressure. And in terms of how people did between those two arms, you can kind of see there's the primary outcome, which is combined of all of these different vascular outcomes. And you can see there's no real difference. Even if you try to really zoom in here, the lines don't really separate. There was a difference when they look at non-fatal stroke. These ones do separate, okay? But the primary outcome was negative, so that subgroup, it's hard to know what to make of that. But the biggest thing that we saw in this group, and I didn't put the whole, it's a big table there, is that the people in the more aggressive arm definitely had a significant increase in adverse events. So they had more episodes of hypotension, as you would expect with a lower blood pressure, but episodes of AKIs, even some episodes of actual acute renal failure, and there's some electrolyte abnormalities as well. So in other words, maybe there was a bit of a benefit in terms of stroke, no overall cardiovascular benefit, and definitely higher risk of adverse effects, getting our diabetic patients below 120. So this would be why, if you're talking specifically about non-proteinuric diabetic patients, We say, yes, we know they do better if you get them, if we know they do, this would be this line down here, we know they do better if you get them below 140/90, but going lower than that, it's kind of hard to say in somebody who doesn't have proteinuria. And we definitely know that if you try to go below that 120/70, that's clearly associated with harm. So you really do have to tread lightly if you're going down into that range. When we look at the proteinuric patients, it's actually kind of funny where we say that, yeah, this is really the group that we care about, but you can see that that's a really low level of evidence, that 2D. It's because we don't really have direct, again, dedicated trial evidence for that. We can kind of extrapolate from our other proteinuric patients, and we do have some subgroups, of patients, and people have done meta-analyses, kind of pulling patients out of various trials where it does look like the proteinuric patients might do better with that lower target, but it's really never been a dedicated thing. And this is why we say, okay, it's a much lower grade of recommendation versus a clear dedicated trial that tells us, okay, get them below 140/90, try not to go too low. Okay, I'm going to talk about one more trial and then we'll be done with trials, and I'm going to help put this all together to see why I kind of went through all of this. And the last trial is kind of the sprint trial. This was one of the, another very, very famous trial and one of the few positive trials we have in the nephrology world up until recently. And this was looking at what they called intensive versus non-intensive blood pressure control, just with a systolic target of 140 versus 120. But very specifically, this is a trial of non-diabetic patients, and this is a cardiovascular outcome trial. So in other words, this was meant to be people at high risk of having cardiovascular outcomes, and what was the blood pressure target for those patients. This is a purely cardiovascular outcome trial. And so similar to all the other ones, we could see that, yes, there was separation of the two arms in terms of the blood pressure they achieved. Same thing, it takes more medications to get there, but people were able to get to those targets, as we can see from these lines up here. And here, though, we do see that there is a clear benefit in these patients, where there's a clear separation in terms of the primary outcome, which is a combined cardiovascular outcome, and even an all-cause mortality. As we dig deeper into the sprint data, we can see that it wasn't really powered for this. You can see a lot of overlapping error bars here, but you can see that basically, as far as we can tell, any subgroup this does seem to apply to, including the specific group of patients, of which there was a fair amount, who had pre-existing chronic kidney disease. That said, similar to what we saw with ACCORD, though, there is kind of, you have to pay the piper somewhere, and this does come at an increased risk of adverse events, including basically all the same stuff we saw last time around. So acute kidney injuries, or even episodes of acute renal failure, hypotension and syncopal episodes, and hyperkalemia, most likely, and issues with hyponatremia, probably because of the medications we have to put them on to get them to that target. So that was my whirlwind of the evidence, but now I want to actually distill it down to what does this actually mean? So I think I do like the statement of saying all blood pressure targets need to be individualized, and that comes from our KDIGO guidelines there. They went out and said, think of less than 120/80, or sorry, less than 120. They don't give us systolic because of the way SPIN trial was designed, saying think about that in everybody with chronic kidney disease. But when you look at the text of that guideline statement, they basically say we place a very high value on cardiovascular outcomes because that is what happens to chronic kidney disease patients. So you should think about that target in everybody, but please go back and individualize it. And that's the actual text of that guideline, which is a lot more nuanced than just that everyone gets less than 120. And so I like to think of it this way, where, it's the risk and benefit, like everything else we do in medicine. And we know what the benefits are. Yeah, they have, if we're just selfishly thinking about their end organs, they might do better in terms of their cardiac outcomes and their renal outcomes, but it definitely comes at that episodes of things like hypotension, orthostasis, for our older patients who maybe were worried about falls and things like that. These are very, very real adverse effects. So I like to kind of balance it and say, what are the things that are going to make you aim higher and what's going to make you aim lower? Why I was focusing so much on the actual evidence is to say that proteinuria really is one of the things that would make us think about a lower target. Not diabetes or no diabetes, which is what some of the original guidelines, some of the older guidelines were written as, right? To say all diabetics, put them below this target. When you actually look at the evidence, we're really talking about, is this a proteinuric patient or not? And how high is their cardiovascular risk aside from, so look at everything else aside from just their kidney disease as well. And in those people, you might go more aggressive. The converse, people who either don't have a lot of proteinuria, or especially those who you think are going to be at high risk of these adverse outcomes, then you might say, okay, maybe I'm going to be a bit looser. And that's the exact kind of way that I think through things too when I'm setting my targets. And you'll often see us send back letters that say I would use a blood pressure target of, less than 140/90 is fine. If I have an older, maybe frail patient with no proteinuria, that's totally fine. Versus, okay, this is someone to be aggressive in. And then the last point that I'll make about the targets is if you are going to be aggressive with the target, this is where you really want to counsel your patient. Okay, if these things start happening, if you start getting lightheaded every time you stand up, you're feeling woozy when you're walking around, you need to let me know. In other words, I often view this, especially if there's not a real hard indication for it, as a one strike you're out type of a thing. That you push harder, they start feeling terrible, or their blood work starts going really abnormal, say, okay, I tried, they didn't tolerate it, let's back off to a conventional target. Okay, so this is kind of a good way that I like to think about those items. And then we'll get to the other half of the coin, and then we'll put this all together. The other half of the coin being, okay, we talked about the blood pressure target, but what about the specific drug we use? Or really the question we're asking is who gets RAS blockade versus any old agent? So when you look at this comes from Hypertension, or sorry, the Hypertension Canada one looks very similar to this, but this is from a different publication. I just like the picture where they said, okay, let's talk about how we manage high blood pressure in the context of kidney disease. There's various lifestyle things that we should do to everybody, and we'll come back to in a second. But then you can see the first cutoff is exactly what we just talked about as well, is proteinuria or no proteinuria, saying, okay, who really needs the ACE versus who can we use something else? So let's go through this kind of one by one again. So this is, again, looking at our patients. You can see they always kind of break things down by blood pressure and specifically this is looking at people with protein. And so once we got into the group that was, this is a meta-analysis of many different trials. There was several thousand patients included in this meta-analysis. Where when we're looking specifically at the group of people who have higher degrees of protein, we can see that kind of they end up doing a bit better in terms of their renal outcomes with when we're using RAS blockade as opposed to any old agent. So this is specifically with ACE inhibitors. But then we also see that it's not just a yes or no type of a thing. So in actually looking at the degree of protein, these numbers are grams per day. So this is like clearly into the nephrotic range, this whole half of the curve. But it's basically a linear type of relationship, meaning that it's a direct relationship between the degree of protein and the benefit you get from RAS blockade. It's almost essentially linear with the amount of proteinuria you have. And in diabetics is actually where we have, a lot of the really strong evidence in this as well. So this is the IDNT trial. Again, this is quite a while ago now, but we still talk about it because it's kind of the cornerstone of what we do. And this is specifically looking at patients with very overt nephropathy. So, about 1 gram of protein per day and randomized specifically to look at the effect of different agents, an ARB versus any old agent. And we can see that the people who we're using the irbesartan, so that's the one that's clearly on the bottom, separate from these other lines, regardless of their blood pressure control. So before we're talking about blood pressure control, here this is now essentially adjusted for their blood pressure control. So same blood pressure, but just being on an ARB, you have a very different renal outcome. So it's clearly renal protective. Similar trial called RENAL around the same time, where this is again looking at diabetes, and you can see less than the previous one. So now we're just talking 0.5 gram of proteinuria. And we see a very similar thing. Blood pressure was similar between the two groups, but the people in the ARB arm do a whole lot better in terms of their renal outcomes. So now to put everything kind of in one picture here, and actually I'm just looking, I think these two slides are out of order. So sorry about that. These slides must have got flipped. So similar to what we did with the blood pressure target, I think this is the way to think about this. Meaning, when we're talking about which agent to use, all the guidelines will say in chronic kidney disease, start with RAS blockade. And I agree with that. That is a good first choice for anybody with kidney disease. But especially if we start running into issues, this is when I really like to show this. Then we need to think about, how hard are we going to push? How much do I really want this person to be on RAS blockade? And what I mean by that is, start there, but then let's say somebody either keeps getting AKIs, or every time you check their kidney function, it's just all over the map, or they start getting recurrent hyperkalemia that's hard to manage. That's where I go back and I like to use the term of, what's negotiable or what's non-negotiable, or sometimes it's, I'll put in my dictation, who has a firm indication for RAS blockade and who doesn't. And what I mean by that is those hard reasons that I really want them to be on RAS blockade, if they have substantial proteinuria, as we just went through, or of course, there's the cardiac indication. So especially somebody who's got reduced ejection fraction, those people clearly benefit from being on RAS blockade. There are strong outcomes, renal outcomes in the cardiovascular space that we're talking about, mortality outcomes, right? So those people, they're kind of stuck with the RAS blockade. You got to do whatever you can to try to make it work for them. But in the absence of that, and I definitely see a lot of those patients, I've seen an older, frail patient who maybe has been hypertense for a long time, but they've never had any significant cardiac issues. They have no proteinuria or minimal proteinuria. If that person's running into issues with AKIs and hyperkalemia, I'd actually say, you know what? There's no reason they must be on RAS blockade. So we could use any old agent that doesn't come with those downsides. So that's where I kind of use this balancing. And the nice thing is, similar to the other one, it's kind of the same types of things that we're talking about. Similar to blood pressure target, we're talking about protein again, because that's really where the evidence comes in the renal world. And we're talking about if they have a cardiac indication, then they have to stay on it, as opposed to any of those other people, maybe we use a different drug. And that's where I like to put them all together, because even though this is a big, I've often found this when I was learning this as well, to be so confusing because it's just a mishmash of different numbers and different evidence grades. When you start kind of saying what's the hard evidence, the real strong outcomes, and that's why I've highlighted them in bold and red, is okay, we got to get everybody below 140 over 90. If you have a lot of protein, you're probably better off using a RAS blockade. That's the real strong evidence. Then everything else is kind of a shade of gray between that. It's like, yeah, probably if they have more protein, we'll push them a little bit to a lower target, but that's a little bit less strong. So, and I do think it's a bit of an oversimplification when they put out those recent guidelines after Sprint to say, think of less than 120 over 80 for everybody. Think of RAS blockade for everybody. Yeah, that might be a good starting point, but I do really, I know I sound like a broken record to keep repeating this, to say it's all about kind of the protein in these patients, because that really will tell you, okay, how hard do you have to push? And do I really, really need to stick with this target? Or if they run into trouble, do I back off? Okay, so hopefully that demystifies a little bit about where all of these guidelines came from. And then the last little item that I'm going to put in is that when you're making these decisions about how hard to push, now let's go firmly back to just the kidney world, right? So if we're only talking about our kidney outcomes, hopefully this, and hopefully it'll be one of the other lectures in this series, we'll actually talk about this kidney failure risk equation. And I think it has kind of made its way through and becoming a standard part of clinical care. If you're not familiar with this, please do check out that website of kidneyfailurerisk.com. So this is talking about the kidney failure risk equation. It's now a very well-validated tool to predict specifically renal outcomes. And when I say well-validated at this point, it's literally millions of patient years of data. And it asks the question is, what's the chance over the next 2 or 5 years that the patient in front of me will meet end-stage kidney disease requiring treatment? So that's actually what that number is predicting, not just GFR less than 15, but actually need for dialysis or transplant. What's the chance that the patient is going to require this? And why I have this plug here, aside from it being a great tool that I think we should be using in all kidney disease, and all of our guidelines will say, please use a validated tool to prognosticate somebody's renal outcome. It also, I think, makes me decide how hard am I going to push with these various measures. And that's where I like to give these different examples. So on this left-hand side of the screen, we have, and again, this is a very typical patient I might see in my practice, that it's an older patient who has a low kidney function. Maybe this is someone who's been hypertense for a very long time, but very minimal proteinuria. And you can see that that person's risk of meeting end-stage disease requiring treatment over the next 5 years, let's call it 5%. So it came out to 6, but just for round numbers, around 5% chance by the time she is 86 years old that she'll get to that point, meaning about a 95% chance she won't. The other example I have here, and it just shows how heavily this is weighted towards proteinuria as well, because that is really one of the strongest predictors of what's going to happen to your kidneys. Here we have someone who's much younger, is starting off with actually a better kidney function, but has a high degree of protein. So this is kind of our typical diabetic with overt proteinuria that we're seeing. And you can see that this person's risk of getting to end stage over the next 5 years is way higher, even though he's got, 10 points more of GFR than this person. So why I put these two items there is when we're talking about things like strict blood pressure targets, needing to be specifically on RAS blockade. Ultimately, we'll even be talking, and again, I think you have subsequent talks about this, other agents like SGLT2 inhibitors and things like that. We're going to be much stricter with this person, whereas, our 81-year-old, actually, we're kind of predicting that even if we do nothing, because that's what this calculator is based on, she already has a pretty good renal prognosis. So in other words, is it really worth adding more medications, driving her to a low blood pressure target when she might do just fine without that? That's where sometimes you have that individualized, decision. Some of our 80-year-olds, yeah, they're doing great. And maybe you do think that they've got another good 10 years plus in them. And yeah, maybe we will be more aggressive. Whereas someone who you might see other limiting conditions come up, actually, they're going to do pretty fine as far as their kidneys go, no matter what you do. So maybe you don't push quite as hard. So that's the last piece of the puzzle. So putting all three things together in terms of what we're doing, we're thinking about what's our blood pressure target and what type of agent are we going to use based on how much protein they have, what's their cardiovascular risk, and what's their overall predicted outcome. Do I really think I'm going to change something overall for this patient or not? And then using those three pieces of information, that's how we individualize our treatment plan. So that was our whirlwind tour of kind of, how we got to the targets, what my approach is to how we select both blood pressure target and choice of agent. I'm going to stop talking about big trials now so everyone can breathe a sigh of relief. No one's going to get asked to regurgitate those trials. And then we'll take you through the last few little items, just a few notes about a few lifestyle measures and things like that. I see someone's got a comment. Maybe I'll go through these last few and then we can kind of come to that in the end there. So in terms of, a few other items here, I think it is worth just kind of going through. So this is not a big debate, I don't think, when we talk about, lifestyle adjustments. I just like to make a few notes about this. So one is salt. There's always, interminable debates about what should the salt target be for the general population. I think, at least in my world, that's asking the wrong question. In other words, you sometimes hear people say, maybe we need to increase the daily maximum daily allowance because maybe 2 gram is not necessarily needed for everybody. That might be true, but when we're looking at specifically people with either hypertension or chronic kidney disease, a very large proportion of them is salt-sensitive hypertension, meaning, and these people, we know they respond to sodium. It's much different than talking about the general healthy population. And in general, I basically tell my patients to lower the better because we're looking at a very selected group of patients. The other item that I like, and again, I think I'm preaching to the choir here. I think it's nice, you hear sometimes all this bad press about various drugs and GLP-1s and all that type of stuff. But I do like that it's kind of, at least in my opinion, put a new focus on maintaining a healthy weight and specifically the fact that we now have treatments that can help people who are really struggling with it, I think is fantastic. And when it comes to blood pressure, I don't have the data here, but the rule of thumb that we often use is even a 5% change That's basically like adding an extra antihypertensive. Okay, there's good evidence that you get about the same effect as adding another pill. By even in a lot of people, that might be talking about somewhere in the 5 to 10 pound range. So it's not like they need to get right down to that healthy weight. Even a small incremental change will have a dramatic impact on their blood pressure. So, so that's one. The other kind of plug that I want to put out there is that a lot of studies have actually been done now, and it's getting more and more into this area of out of office or home-based blood pressure monitor. Out of office because it can include also an ambulatory 24-hour pressure. And we're seeing that actually for diagnosis, it's better. For monitoring, it's not as clear. And what I mean by this is actually when you're kind of using the ambulatory blood pressure monitor as their gold standard, we probably overdiagnose hypertension based just on office measures. So, it is always a good step that if you're starting to see blood pressure to recommend home monitoring or to get a 24-hour if you're not really as clear. The evidence base is building for monitoring. It's just not as strong for diagnosis. That's why it's not on this little algorithm here. But home blood pressure monitor, basically, my practice is if someone is diligently monitoring their blood pressure at home and they've had their machine calibrated, I don't even check it when they walk through the door because frankly, I know that whatever I'm going to get is less accurate than what they're doing at home, as long as we know their machine is working okay. If you are, we all obviously, you can see actually in the background of my picture, my little machine sitting there. Of course, where there are situations we have to measure it there. Just a little bit of a plug just to remind everybody that, the gold standard recommendations here is that although sometimes the machines are finicky, but they have been proven to be better than us using our ears, so we should be using that. But if you are using it, the real trick is having several averaged readings, right? And ideally, what I do, I've got the machine sitting there, but I'll set them up. You walk out of the room, I'll go get my drink of water, whatever I want to do, come back after it's averaged a few measures, because that really is, if you're doing an office-based blood pressure monitor, this is the recommended version of doing it. The last couple of items that I'll bring over is you can tell I'm a big proponent of home blood pressure monitoring. The one thing, though, is that really patients need to be instructed on how to do this, and there are some good resources for this. Hypertension Canada has them. We have them on our BC Renal website as well that gives people very, very clear instructions for monitoring their blood pressure. And it's important. We actually, a few years ago in BC, we did an analysis on this based on our CKD population. So these are people even in our multidisciplinary kidney clinics. And we did a survey of patients, and we found that actually a large number of people were doing home blood pressure monitoring. So we thought, yeah, we're doing great. Everyone's monitoring their blood pressure at home. But when you ask the patients, did anybody ever measure your arm to make sure you have a good fitting cuff? Did anybody ever tell you how to measure your blood pressure at home? And did anybody ever clearly communicate your target to you? What should your blood pressure target be? Unfortunately, on all three of those things, we didn't do that great. So in other words, we were telling people go off and do your blood pressure monitoring, but one of the gaps was that education piece. So I think it really is important, again, if you're going to be trusting it, the home measures, is to make sure that people are doing this. I love this little one-pager from the Hypertension Canada, this little picture. It's got it all in one-stop shop. They can just print it off and put it right beside their machine, type of thing. And then my last little item, then I'll open it up for questions here. So we talked about, all the various medications. I just want to bring this in because it's such an important consideration, especially as we're getting into multiple agents here, is sick day management. And I think, you guys are all very, very well familiar with this concept of the sick day list. There's more and more drugs in the kidney space that people are going to be on. They're going to be on their ACE inhibitors, their SGLT2s. We're going to have add a whole other line, not just for water pills, but mineralocorticoid antagonists and things like that. And, I always tell these patients they should have one of these. I have a stack of them in my office. I hand them out, but remember that a lot of these, it's not just about being sick, but the reason that these have these impact is actually if you're underperfusing your kidney. And so in other words, symptomatic hypotension, same type of thing to hold off. And then the last little plug, I didn't put this on the slide, but there's actually, been some debate in the renal world lately about whether we should even be suggesting this to people. Some of you may have seen, this is about a year or so ago now, there was an interesting analysis that said that actually patients who did this tended to do worse than patients who didn't. And it's not that the sick day management is the wrong thing. What the problem is that a lot of patients are on these drugs for a reason, right? They've got significant cardiac disease, kind of one of the predominant drivers. And what they found is that often somebody would go to hospital, they had their AKI, so their SGLT2 and their ACE inhibitor and maybe their MRA, everything got stopped, and then it never really got reintroduced down the road. And that probably explained the reason that some of these patients had worse outcomes and specifically some cardiac outcomes. So in other words, my plug there, it's not to say that sick day management is a bad thing. I don't think that's a take home from that study. I think the take home is that when people do this, make sure you have a plan to reintroduce. And then if there's questions, of course, that's where we're happy to be involved as a nephrologist. But otherwise, so, that was my whirlwind tour of hypertension management. Hopefully it helped kind of demystify those couple of questions of what exactly should my target be and how hard should I push with these couple of medications. And then with that, we can individualize our targets for our patients. And so with that's the end of the whirlwind tour there. And then I can open it up to some questions. I know there was one earlier. Please do let me know if you have any questions there. Can we unmute people? I think Sidonia, maybe I should have asked that, or do people have to type it in?
I think I can unmute them if people raise their hand.
Okay, cool, perfect. Either way, here I can maybe even just gonna pull it up so I can see everybody. Maybe there was too many trials and too many numbers, for people to have those questions there. Let me just see. Oh, okay. So there's a typed question here. What are the percent? Oh, okay. Yes. So, in terms of the first one, so the kidney failure risk tool. Yeah, so that's a good question. So we would say that, anything less than about 3% is considered a low risk patient. Somewhere in the 3 to 5%, that's where we say, okay, they probably should be being followed by a nephrologist. 10% 2-year risk, that's where we say, they should probably be followed in one of our multidisciplinary clinics, and there's some evidence behind that. And to kind of help put things into context, it might seem lowish, but 40% 2-year risk, that's actually where we start preparing for things like dialysis and transplant. So in other words, once you're getting into even the 20+% range, that's where this is somebody who's really clearly progressing. And if they do have that expected, life expectancy ahead of them, that's kind of the numbers that we use. So I mentioned those numbers to say the short answer is it's a lot lower cutoffs than you think to call somebody a higher risk patient, right? So especially because a lot of them, even though in our kidney clinics, only the minority go on to need dialysis, we kind of want to have everything in place before we get to that point. So if you were to pick a number after about 5%, that's where they should at least be seeing one of us nephrologists, and then we can help with some of those thereafter. So the relative risk reduction of intensive versus the lenient blood pressure target. So yeah, we only have those couple of trials to go off of, right? And I'll combine it actually with the other one where you say difference between 120 versus 130. So the short answer is not directly compared. The only one that really kind of did that would have been the Accord trial. And specifically, when we're looking at the 120s, we're really just talking about cardiovascular risk. So I'd have to double check, and I can go back and look at the exact numbers to kind of actually give you, absolute numbers and everything like that. But in terms of direct comparisons, no, they're not out there. And that's where I'd say that really it's only if you're thinking about cardiovascular outcomes that you really push people down to 120. Should be using intensive control if their kidney failure risk is greater than 5. Yeah, so, so good question. I think if they're getting into that realm, probably they have some protein. Again, to me, it's all about the protein. And I say probably they have some protein because it's hard to get into the higher risk scores without having some significant proteinuria. But I think it's reasonable to try. My approach for those patients is I think it's reasonable to try for most patients to get them down to a really good blood pressure. I kind of look at this as if you're running into trouble, how hard do you push? You know what I mean? So in other words, if somebody's got a fair amount of life expectancy ahead of them, I think in anybody, just like they say, consider getting them even closer to normal. We know they do better for many different outcomes there, but for the patients who start having hypotension, AKIs, issues with the potassium, things like that, that's where you then take a step back and say, okay, is it the risk outweighing the benefit here, or is the benefit outweighing the risk? So I do like the concept of think low for everybody, but then, okay, then decide if we start running into issues. Um, Perfect. So yeah, perfect. Oh, thanks, Katie. I'm just reading through the questions here. One of them said, okay, right. So yeah, so 3% below, yeah, to get those specific categories. And I think this is going to be covered a different one. To be specific, we say that below about 3%, we actually know that there's a very, very low, even long-term risk that those patients end up on renal replacement therapies. And there was a trial out of Alberta, actually, where they looked at this and said that people below 3% could actually be discharged from nephrology, followed in primary care, and they did fine. Nobody went on to renal replacement. So that's where that number 3% comes from. To say below that, we're very confident they could be managed. You guys, do excellent, and they can be managed in a primary care setting. Of course, any worries, always let us know, but that's the general rule of thumb. Why I say above 5%, by that point, that's probably where they really should be seeing a nephrologist. In that 3 to 5% risk, honestly, they are still a fairly low risk patient, but it's kind of like once they're creeping up above 5, okay, by then they probably should have seen someone. Again, any specific questions or worries in between that range, we're happy to see them, but that's where we really should know the patient after that point. And then the next question saying, okay, people with high-grade proteinuria, right, where do we go after the RAS blockade? Okay, because I didn't get to that point. I said RAS blockade, and then the question is, what do you do after that? So yeah, interesting. I didn't get in this far into it, but there might be some slight additional antiproteinuric benefit of the calcium channel blockers, and that's why that one comes up. So that I think is a good choice for a lot of people. The one caveat that I give is that now we have a couple of different things that come into the mix. So there's also, and I didn't get too much because we're talking just about blood pressure management, but now we have SGLT2 inhibitors that we use in people with high-grade proteinuria as standard of care. That's something we add to the mix as well. But then the next step after that, and why I mentioned that one is that SGLT2 inhibitors, there is some evidence that they might help with potassium control, because that's the next step where I go to after that. In other words, I try to maximize the RAS blockade as much as possible. If I start running into potassium issues, that's often where I'll add in a thiazide type diuretic. One drug makes the potassium go high, put another drug that makes the potassium go low, and then see, do I get a little bit more wiggle room to really maximize their RAS blockade? Because that's always my first priority. If not, then that's where I would go to a calcium channel blocker. Or if I've got them to a full dose of RAS blockade and they haven't had potassium issues, then yeah, I would go to a calcium channel blocker as my next agent. But yeah, to me, the first thing is if it's someone I've decided that they're going to benefit from RAS blockade, I do whatever I can to try to get them to the maximum possible dose. And a good tool to have in your toolkit for that is to use the thiazide diuretics. There was even a recent, people are always worried about that in kidney disease, but there was a recent, it's about 2 years ago now. I think it was in New England. I forget if it was New England Journal or JAM. I think it was New England Journal, where they actually looked specifically at thiazide type diuretics in people with chronic kidney disease, GFRs below 30, and they still maintain their antihypertensive effect very nicely. Chlorothalidone is the one they studied. It's always the one that has a bit of a better evidence base than hydrochlorothiazide, and it is more potent. Downside is it ends up on back order a lot recently, but otherwise, if you're doing it, I tend to try chlorothalidone. But regardless, is to say the thiazide diuretics do work quite nicely in our patients with kidney disease. Oh, perfect. Yeah, thank you. Thanks, Mario, for the comment. Yeah, great. I'll maybe wait a moment here if there's any other comments or questions either people want to type in or feel free to take yourself off mute. Great. I'm just flipping to the various different chat things. Okay. Oh, do I still use your PCR? No, not really. That's kind of, yeah, we just use ACR across the board. PCR, the one time we still sometimes use it is in our pregnant patients, just because a lot of the cutoffs there are still based on PCR. But over the years, as more of our data has been based specifically on ACRs, we've kind of made a wholesale switch to ACRs. Yeah, pregnancy is the one time we'll still use a PCR. Pediatrics, they use it a little bit more as well, but in the adult world, ACRs. Great. So otherwise, if there's no other comments, we're getting right to kind of the top of the hour here. I know it's always, hard to go through a whirlwind tour of many different studies, but thanks all of you for all of your attention and excellent questions. And hopefully that helps with some of our control moving forward. As always, whenever there's questions, we're just a phone call away. Hey. Oh, and thanks, Sidoni, for that, both in terms of posting and that information. Okay. Have a good rest of your day, everyone. Take care.